Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everyone. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin.
You fade out to like a whisper. Okay, good. Well, in this episode, we're going to talk indirect treatment comparison. So because I know nothing about this topic, or I don't understand the statistics and the principles behind it, I'm going to make you explain it to everybody, since you're also an author on this newly released paper that's getting a lot of publicity. But James, before we do indirect treatment comparison, let's do a rapid fire. Do you know this thing, the peak, the pit, and the bud? Have
No.
you ever done that?
What's
So
that?
where you maybe like at the end of a day, the end of a holiday or something, you think about the peak of the day, the pit of the day, and then the bud would be, what are you looking forward to, next? The next day?
Wow.
Is that too philosophical? I'm thinking since you just came off nice holiday time, did you have a peak, a pit, and a bud?
Oh, I don't know if I could answer the bud bit. Peak. What's the? Yeah, all the situations where I was getting a bit of time to myself, probably, and not constantly having to kind of deal with issues, shall we say. And then pit, family arguments. I'm not sure I should go into any specifics with children.
Not a broken tooth. Not a broken tooth. It's family.
No. Oh, no, broken tooth's nothing, actually. I mean, there probably are. Yeah, okay. So I had a broken tooth the other day, but it didn't hurt, and I got it fixed pretty quick. But
That's true.
I mean, I actually, honestly, I think kind of like arguments are much more stressful than that. I mean, it reminds me of the whole bowel prep thing, right? Like.
Good analogy. Go on.
Well, so, people say, bowel prep, it's really horrific, all that sort of stuff. When I did it, I didn't really, yeah, exactly. I didn't think it was that bad. And honestly, I go through more pain most days, for other reasons.
Right.
Than having some bowel prep. So, I don't know if that's a good analogy or not, but the tooth is now fixed, as we discussed, and you can't even tell which one it is. So there we go.
Good. You can take guesses on this. And no bud? Nothing you were looking forward to as the holiday was coming to an end?
Oh, honestly, the fact that ESMO is really early in September is kind of not that helpful, frankly, because I knew in my own mind, as soon as I get back, I'm going to have to, a lot of my other colleagues are on holiday at the moment. And so then I get back to like really busy clinics, loads of problems to deal with. And then on top of that, talks to write and all that sort of thing. Yeah. Plus, there was a lot of email activity as well in August with ESMO being in September, which is also, holiday wise, kind of not that ideal. So, to say I was sort of looking forward to any of this would probably not be true, actually. But, it is what it is.
Yeah. I mean, I think maybe some other time we can talk about time management strategies or how to manage the colossal email dump that happens when you're on holiday and not come back to either a, pile of it or.
Oh, well, I mean, I can answer that now from my perspective. I think the only way to do it is to be really disciplined when you're away. I mean, so I don't know if we talked about this before. I can't pick up my work emails on my phone deliberately.
Yeah.
So
yeah.
when I go away, I just take my laptop with me, and then normally in the mornings I open it, I do my email, probably half an hour max. I close it again, and then I wouldn't do it again until the next day at the very earliest. And so then if there's anything urgent, people could just call me or message me. And I actually find that much a better way to deal with things than get back to 4,000 or 5,000 emails and then a busy clinic. It's just not doable.
But you don't find that people I think the hardest thing is setting the boundary that my availability will be that limited portion of the day. You don't find that they bleed past it. Oh, this is urgent, and this is urgent. So I'm going to break into your afternoons and evenings.
Yeah, there's the very odd thing that really is urgent, but it isn't much actually. And
Yeah.
I normally say, I mean, there were one or two things happened when I was away that could have been urgent. And then I'll just normally say via email, look, if this is urgent, then message me on my phone, and they got my number. And that's actually
Yeah.
quite a nice level of separation, or an extra barrier in a way, because people then know specifically that they're going to be interrupting. And
Yeah.
I don't think most people abuse it. In my experience anyway.
Yeah.
But who knows?
It's everyone else's definition of urgent may not be urgent, truly urgent. Like don't make your lack of preparedness my urgency
Yeah,
or emergency.
yeah, yeah. I mean, listen.
So
I think the only things that really ever are going to be truly urgent are going to be clinical things, basically. And
finish up
and
that.
we
Yeah.
yeah, and we all work in teams,
Yeah.
and so there's always people around to deal with things. Actually, so yeah.
Agreed. Okay, well, welcome back.
Thank you.
Let's talk about this paper. I just had it pulled up and somehow toggled away from it by accident. So this is the first line Nevolumab plus Relatlimab versus Nevolumab plus Ipilimumab in advanced melanoma, an indirect treatment comparison using Relativity 047 and Checkmate 067 data. And James, you're an author on this by virtue of the 067, I think. So, you must have seen a version or two of this manuscript and have some idea what you guys are trying to convey here. Can you tell us?
Yeah, well, first thing to say is I'm absolutely not an expert on any of the statistical methodology here. And actually, to be honest, over the years, I've been involved in a few of these indirect treatment comparisons, and quite a lot of these happened in kidney cancer, a few years ago, at least 10 years ago now. So it's an accepted methodology, I think, is the first thing to say. It's used quite widely. Quite often by health technology assessment, sort of reimbursement type bodies. There is a methodology and there are experts in this, but at the end of the day, it's a way to try to compare different data sets and to try to control for everything that can be controlled for in the analysis by doing it at an individual patient level. So I think you look like you're poised with a question.
No, I was going to say we talked about this within the uveal melanoma episodes we did. There was a nice, propensity adjusted comparison between Ipnevo and tebentafusp. And I sort of threw my hands up on that episode, sort of saying, I don't understand it. I mean, I believe it. I trust the authors and I trust everything, but I couldn't find a way to articulate it. And what you just said is far smoother and better, I think, which is, look, we may not be the experts, but there is methodology for this. It is a valid way to compare studies. Yeah.
Yeah, and you might not like it, right? One might not like this, and I guess we're both aware that there's been some fairly vociferous comments about this, but I think it'd be wrong to say that it was invalid. I think it's an approach to a problem which is a legitimate approach. It's not perfect, and of course the risk with all of these things is that you've got your kind of known factors, but of course it can't by definition control for unknown factors. And that's one of the issues here for me. What are the unknown factors that may have affected efficacy? In this case, in these two trials that were done at quite separate times, where a lot of factors changed over those times, some of which we know, some of which we don't know, and you can't control for that. But nevertheless, I think it's a reasonable exercise, would be the first thing to say. And also, if it ends up being important for HTA's reimbursement, that kind of thing, then I think that's a positive thing, because the reality is, particularly ex-US, if I might be so bold, this is the kind of evidence that people are sometimes asking for. So I think it's a reasonable exercise.
So tell us how, or, maybe take us through the paper if that's the easiest way.
Yeah, so just out in JCO, Georgina Long is the lead author, Dirk Schadendorf. as a senior author, and most of the authors are people involved in either Checkmate 67 or Relativity 47, along with people from BMS, some of whom actually are experts in this methodology, I should say, and then one or two people from another group, actually, who again will be experts in this methodology. So the purpose, I think we've sort of discussed already, which is to try and compare these two trials, these two data sets using patient level data. I think going into the exact statistical methodology, well, A, I don't really understand it, as we've said already, and B, I'm not really sure it's going to be particularly helpful. Yeah. I guess, maybe one thing to say, that the trials were sort of lined up as closely as they could be lined up. So I've mentioned already this issue, the trials were done at different times, but the follow-up from each trial was done at about 3 years, so 33 months minimum follow-up for Relativity 47, 36 months for Checkmate 67, so to try and, if you like, align the two trials with one another. And the bottom line, and I'm just looking at the results now, is that in terms of PFS for these two regimens, so that's Ipnevo or Nevo RELA, adjusting or taking into account baseline characteristics, were fairly similar, with a hazard ratio of 1.08 and a confidence interval about 0.9 to about 1.3. Same true for response rate and OS and melanoma specific survival. So I guess that's the sort of, let's call that the efficacy headline, if you like. Maybe the interesting thing, or the most interesting thing about this, is that there were some subgroup analyses which actually did show larger differences numerically favouring Ipnevo, and those ones, and this is all in the abstract actually, were acral melanoma, BRAF mutant, LDH greater than twice the upper limit of normal, all of which to me feels completely biologically plausible. So, and to some extent, I think chimes in with not just what you and I think, but what a lot of people think about, let's call it, the strengths of Ipnevo. So if you wanted some sort of validation in a very subjective, kind of relatively soft way, maybe that's it, actually. It's kind of told us something there that we sort of thought we knew already. If you look at tox, treatment discontinuation, grade 3, 4 AEs, then obviously there was less of that for Nevo RELA than Ipnevo. Again, I'm not sure you needed to do this analysis to know that. I think we could be confident actually about the tox by just comparing the trials, as they've been done and as they've been reported. So, I think a worthwhile exercise, but at the end of the day, I think clinicians, if they have a choice between these two regimens, obviously need to do as they see fit. And we've discussed some of that already in talking about Ipnevo and Nevo RELA.
Yeah, so I think that's a great walk through the paper for people who might find it pretty dense with kind of graphs and subgroups and comparisons. Maybe a few questions. For these subgroups that show benefit, you said it makes biological sense or plausibility that some of these look better with Ipnevo. We've talked offline a bunch, and maybe even on this podcast a few times, about LDH as an interesting biomarker. I'm finding I have to manually add it into my treatment plans here and sort of bring it in more because it doesn't seem to be a routine lab test. But really, I actually find that LDH quite useful. And here it seems to pick out a group of patients for whom maybe is your takeaway that Ipnevo clearly is doing better. Maybe clearly is too strong a word, but trends to be doing better when you have 2 times upper limit of normal?
Yeah, I think so. And we've been using Ipnevo for a long time, haven't we? So and I've said this before, but we've got the trial, and also we've got our own clinical experience of treating these patients with bad disease. And I think you and I wouldn't be alone in thinking that in terms of potency of a checkpoint inhibitor regimen, Ipnevo is the thing that we've seen so far that feels like it's the most potent, again, from clinical experience and from the trial. So then you look at Nivo-RELA, same question, clinical trial, clinical experience. Does it feel like it's better than Ipnevo? No, it doesn't, basically. And
Right.
so I think in a sense that the Ipnevo is sort of the benchmark for this group, bearing in mind, though, that even with Ipnevo, actually, although we do see efficacy sometimes, actually most of the patients will not get benefit from treatment. And then maybe that's just a little segue into sort of newer strategies, which you talked a little bit about before, triple therapy. So
Or this
anti-CTLA-4,
high LDH group.
Yeah, many of whom will be early progressors. They'll progress on the first scan. And then, the data that we've just seen, Relativity 48 that Paolo Ascierto presented at ASCO, one of my takeaways from that, and I said it at the time, I think, was that it looked like, in as much as one can take a view on this from a relatively small number of patients treated at specialist centres, but it looked like those patients who often will drop off early on the first scan, it looked like there was less of that early progression with the triple therapy.
Right.
So I think that's quite an interesting point, needs to be investigated further. But
So this idea about potency, does this indirect treatment comparison help us with that difficulty when you as an inexperienced person look and just do cross trial comparisons and you say, well, Nivo-RELA has a 44% objective response rate. Nivo monotherapy in Checkmate 067 had about a 44% objective response rate. Does this type of indirect treatment comparison help us sort of square that in our heads? It's not that we think those objective response rates are actually similar. It's when we start looking doublet to doublet and do an indirect treatment comparison. And I think what ends up happening is you have to then account for imbalances in this enrollment and this demographic. So you kind of shake out outliers and other things. And now you can compare these doublets a little bit better. You guys also compared the Nivo monotherapy arms in these trials, right? And did you find that the monotherapies looked similar? Because I think when you do cross trial, you think these are different Nivo monotherapy groups.
Yeah, well, actually, during development of the manuscript and discussions, that was one of the points that I was most focused on, because, if this type of methodology is to be believed to have credibility, and I said this sort of in words of one syllable, then the monotherapy arms need to look extremely similar, which I believe they do, basically. But yeah, I can't understand how you can compare doublets if the single arm doesn't look the same, or at least very similar. And it doesn't. I mean, we talked about this before as well, these differences in response rates. There's a load of different factors in there. I've got an incredibly simplistic view of this, as you know, which is that, adding Nivo puts something on the upside, adding Ipi puts something on the upside. And of course, the $64 million question is how much and how does that square up? But it certainly feels to me, I guess, from everything I've seen and done to some extent in clinic, that upside for Ipi is bigger than it is for RELA, which I've said before, and I think that's real. And of course, obviously, the toxicity is more as well. That kind of goes without saying.
So maybe last question is about what's the biological plausibility that the BRAF mutation is somehow responding better with Ipi as a partner rather than with RELA?
Yeah, well, I mean, again, I think we've talked about this before, and I certainly don't know the answer to that. This wouldn't be the only data set, obviously, where that observation has been made. There's several data sets now. I'm not sure that anyone knows the answer to that. I mean, there's all sorts of different hypotheses, but I don't know. But certainly in my practice, even in the last few years, I mean, honestly, to start off with, I was a little bit equivocal about that observation. People talked about it a lot, and I was thinking, oh, well, subgroup analysis, all that sort of stuff. But now you've actually got multiple data sets pointing to the same fact. So I think for me, 40% of people have got BRAF mutant melanoma. I think the standard of care is going to be Ipnevo, period, as you would say, or you might say, in patients who can tolerate the treatment, and then and there's no obvious reason not to go with that treatment.
Okay, that's what I was going to ask you, a real world question, but you just answered it. If you have a BRAF patient in your clinic, normal LDH, you feel comfortable that they can handle doublet. They're in their frontline metastatic experience. The doublet you would choose is Ipnevo, because this indirect treatment comparison is really telling you those BRAF mutated patients, that subgroup, seems to have a stronger benefit from one doublet over another.
Yeah, I might just slightly soften the last bit of what you said.
Okay.
I think you might have said confirm or something. I would say provides further evidence
Okay.
that just because I think with all of this stuff, none of this cast iron, right?
No, no, yeah.
But I think it's one of several things that points in that direction.
Yeah.
And just a bit of a thing about LDH and bad disease and all that sort of stuff. We know that Ipilimumab, is the most active regimen, I think, in these bad patients. But then if you start looking at the efficacy in quote unquote good patients, you're really talking about very high figures, in terms of response rate and so on and so forth, well over 50% actually, if you just pick out response rate. So in my own mind, I'm pretty comfortable with that.
So maybe I can ask you one more question, even though I keep saying it was the last.
It's the last one, promise.
It's the last promise. These high LDH patients that have a BRAF mutation, might you start them with targeted therapy before getting them onto a normalized LDH and sliding them into Ipilimumab?
Yeah, I mean, again, we talked about this a bit before. You've got Succumbit, you've got that subset from the EBIN study at ASCO this year as well. I don't think really this has been bottomed out properly in clinical trials, honestly. So I don't think we really know the answer. We can't, from a reimbursement perspective, but so that's one thing to say. Is it a reasonable strategy to do that? Yes, I think it is. The $64 million question is, how long do you treat people for in that situation? Yeah. And as I've said several times, I think now, I don't really see that there would be a kind of one size fits all in terms of your run-in. I mean, ideally, what you would want to do is, and this is going to vary from patient to patient, I think, give enough treatment to kind of get the disease under control, debulked, if you want to call it that, get the patient more immunocompetent, hopefully. But what you don't want to do is be treating someone past progression in that situation. You really, so that's the big question, actually. And again, to really bottom that out, I think we'd need a decent randomized trial, which was specifically answering this question.
Yeah, although this gets me back to LDH being kind of a nice, after all, biomarker. Yeah. Maybe, if it's high and you can normalize it, you can check it weekly, and then once you normalize it in a country like the US, where I don't have to treat to a certain amount, or, the reimbursement may not be my biggest obstacle, maybe that's what I should do. Maybe I've got the high LDH patient. This paper tells me Ipnevo, but we also know from DreamSeq, those are the patients who might struggle with immunotherapy first. So maybe if they're high LDH BRAF positive, maybe I treat them with a BRAF MEK inhibitor to LDH normalization quickly and then do a switch. But a controlled trial to do that would be far better. So agreed.
Yeah.
Great. Any final thoughts on this one that
I don't think so. I mean, it's nice to go into JCO, and it'll be interesting, I think, to see how it's received, and it'll also interesting to know, I think, specifically how much it really does help with HTA reimbursement type discussions around the world. Whether we'll really get an answer to that, I don't know, because to be honest, a lot of those discussions aren't in the public domain, but I hope it is helpful for that.
Well, great. Well, thanks for this discussion then.
Thank you.